Hi, my name is Dr. William Camann. I'm the Director of Obstetric Anesthesia at Brigham and Women's Hospital in Boston, and we're here at the IsisParenting Center in Needham, Massachusetts to discuss some things about anesthesia for childbirth. Now, epidural anesthesia is a very common type of pain relief. It's used in about 75% of women in the United States, and those numbers are pretty typical for the hospitals around the Boston area as well. I have with me Amanda, who is due in a few weeks, and she has graciously volunteered to help with some demonstrations of the anatomy and the positioning for epidural anesthesia. Now, many patients are curious about what does this look like, what do the needles look like, what does the equipment look like, what type of position do I need to get into to have the anesthetic, and I'd like to demonstrate in the next few minutes the answers to some of those questions. So an epidural is an anesthetic which is delivered to the spine. It's inserted through a catheter, which is placed in the lower part of the back, and then anesthetic medication is injected through that catheter. And I'll talk in a few more minutes about some more of the details related to that. But first, I'd like to demonstrate what the equipment looks like and what the position looks like for placing this type of an anesthetic. So the patient will be sitting just as Amanda is on the edge of her bed in the labor room, and she'll have some monitors attached, usually a monitor for the baby and also an intravenous. And the position for this will be sitting just as Amanda is now, but in a leaning forward position just like that. An analogy that I often tell patients to do is imagine they are putting on a tight pair of pants. And as you put on a tight pair of pants, you have to suck in your abdomen. And by sucking in your abdomen, or some people say letting your belly button hug the baby, you will then push your back right out into the optimal position. So Amanda is right in the perfect position. And what the anesthesiologist will do is feel the hips. And this will give an idea of the appropriate anatomic landmarks. Once we feel where that is, we'll make a small injection in the skin of the back, which feels like a small pinch, and that will anesthetize a small area of skin, roughly around about the size of a dime or a small coin. And then the epidural needle will be inserted through that anesthetized area of skin. So I have an epidural needle here, and this is what the needle looks like. And once the area of skin is anesthetized, the patient will just feel a small amount of pressure. And as the needle is inserted, the anesthesiologist will use various techniques of the feel to identify when they're in the proper space. That's the epidural space, which is the space outside the spinal cord, which contains the nerves that go to the lower portion of the body. Once the needle is in the right space, a small catheter will be inserted. Now, a catheter is a tube. It's a very small, thin piece of plastic. It's about the size of a piece of spaghetti, and it's very flexible. You can see this is an actual epidural catheter here. So the epidural catheter will be inserted through the epidural needle into the epidural space, and then it will be taped to the patient's back, just like this. It'll come up the back with a big piece of tape. It feels like a big Band-Aid being applied. And then the end of the catheter will go over the patient's shoulder, and that will be attached to a pump. And that pump will deliver the anesthetic medication throughout the course of the rest of the labor. And I'll talk in a few moments more details about the way the administration is handled with the medications through the pump. So to get a better idea of what goes on the inside of the back, I have a little model here. And what the anesthesiologist will be feeling on the hips, when they feel the hips, is these bones here, which are the hip bones. And this will tell the proper position. The anesthetic will be administered roughly about the level or just above where the top of the hip bones are. So they'll be feeling the hips. That's why they want to feel the side. And then what they'll do is they'll feel the middle of the back. So they'll usually run their fingers down the middle of the back, and this will tell where what we call the midline is. It will also allow us to tell if there are any abnormalities of the back, such as scoliosis or a small curvature of the back. If there is, that still allows the epidural to be administered, but there may be some slight adjustments to the angle that the needle is inserted. So if you have some degree of scoliosis or curvature of the back, you can still get an epidural. In most of the cases, it still works just fine. So what happens when the patient leans forward, this opens up some of the spaces between the vertebral bones. The vertebral bones are like building blocks of your back, one on top of the other. By leaning forward, you open up the spaces between the bones, and that allows the anesthesiologist to insert the needle between the bones to the epidural space, as I mentioned earlier, the space where the nerves are that go to the entire lower portion of the body. Once that space is accessed, the catheter will then go into that space, just like this, and as I demonstrated a few moments ago on Amanda, it comes up the back, over the shoulder, and is attached to the pump where the medication is administered. And that basically is the anatomy of how the epidural is inserted. Now, one additional thing I'd like to mention is that in some cases, an additional technique called a combined spinal epidural is administered. In that case, we do both an epidural and a spinal anesthetic. And the way that works is the epidural needle is inserted the way I demonstrated earlier, and then an additional needle called a spinal needle is inserted through the epidural needle, and a little bit comes out at the end of the epidural needle that goes into the spinal space, which is one space deeper anatomically in the back, and medication is injected directly into the spinal column or the spinal fluid, and this allows the anesthetic to take effect quicker. In many cases, this allows for a very good pain relief without blocking any of the ability to move the legs. So we often use this in patients that are very late in labor, very advanced, maybe very close to delivery, to allow very rapid onset of profound pain relief and still allow the ability to move the legs and participate in the pushing process, since that's such an important part of the whole delivery phase. So a combined spinal epidural may be administered in some cases, and that depends largely on the stage of your labor and also on the preference of the hospital and the anesthesiologist. Most of the Boston hospitals use both epidural and combined spinal epidural anesthetics as part of their labor anesthesia. So that's a bit about the anatomy and the technique and the equipment. And thank you, Amanda, for participating.